Thank you, thank you. Good morning, 8 a.m. We appreciate you being here. Well, I myself had a hard time waking up, and we know there are very compelling sessions going on at this time, so I appreciate you choosing our session. Maybe you are going to replace your pumps at your hospital. You're curious about infusion pumps, or is anybody going to replace their fleet anytime soon? Yeah. Oh, good.
Yeah.
Good.
What? June though. Oh
man. So we really hope that you get something helpful here. Always try not to reinvent the wheel and try to leverage lessons learned from other institutions. Our deployment was quite substantial, as you can see, but we know there are other health systems that have even more pumps, as I heard. So yeah, let's get started. My name is Michele Manzoli, and I'm the current manager of the clinical engineering team at Cedars-Sinai, based in Los Angeles. I'm also on the board of the American College of Clinical Engineering. That's a great advocacy association that I invite you to check out. We organize educational webinars, symposium, both at HIMSS and AMI conferences. So coming up, a very interesting symposium in New Orleans. I'm a certified clinical engineer, so again, I invite you to explore that professional certification. And I'm originally from Italy. I work in regulatory affairs for the Italian Ministry of Health there, then for a short period in the UK, and then I moved to the US around 11 years ago, first in Connecticut at Yale New Haven Hospital, and then for the last 9 years, I've been at Cedars-Sinai. I started as a clinical engineer, and now I manage the team.
Mine will be much shorter, unfortunately, but my name's Gianna Vanchieri, everybody. I'm currently a clinical engineer at Cedars-Sinai in Los Angeles. And then I got my Master of Science in Biomedical Engineering from USC. So there's me Trojans, fight on.
All right. Next. All right. We need to push really hard, right? So maybe you've heard of our little hospital. It's it's a large academic nonprofit medical center based in Los Angeles. It consistently ranks among the top hospitals in the nation for specialties like cardiology, GI, orthopedics, oncology, and clinical engineering. No, I'm kidding. There is no ranking for clinical engineering, but maybe one day there will be, and we hope that we'll be up there. It is part of a health system. So there are other hospitals that are part of the Cedars-Sinai health system. One in Pasadena, Huntington Health. One in Torrance Memorial, and the Marina Del Rey Hospital close by. So it's really a complex of both hospitals and clinics, outpatient clinics, surgery centers. That's what we call the medical delivery network. Why am I underlining this? Because the project involved the whole health system. We have a team of around 30 staff members, and we manage over 30,000 assets. So thinking at the title of this presentation, you soon understand that the infusion pumps represent almost 20% of our inventory. So definitely important, and I believe in your case might be a similar ratio. All right, our agenda for today. Brief project overview, and then we will dive into each of the project phases, from the vendor selection. The planning took many months, device preparation, training, both on the clinical side, on the cleaning side, and on the support biomed side, deployment, post-deployment activities, lessons learned, what we are still monitoring today to make sure that all the changes that we implemented are still in place, and then we'll leave, of course, some time for Q&A. This is a project as much as it is about technology, it is about people, processes, workflows, change, opportunities to improve. So we know that technology is only part of what we do. We also work with people to make sure that the technology is used efficiently, safely, and how it's supposed to be. All right. So as it's usually the case, we had an aging fleet of infusion pumps. You can see here the histogram that we produced. Every column is a year of age. So you see the two spikes here. This is the 6 to 7 year old pumps, and this is actually 9 years or older. So almost 30% was over 9 years old. Some dated back to 2005, which is something that is still boggles my mind. And we were able to still use almost 20-year-old devices, still being maintained properly, still being used. But of course, many, of course, were beyond their end of useful life, and yeah, definitely was time for a refresh. As equipment ages, it increases the chance for malfunction, compromising patient safety, of course. And speaking of safety, there were many recalls or alerts that had been issued by both the FDA and the manufacturer. Now, can anybody guess the manufacturer? Very good. Yes. Yes, indeed. So we had enough of recalls and whatnot. It was really time to possibly change or to do something and go through the process of yes.
What year was that?
So this was last year. Yeah, last year that was our picture of age, very skewed towards.
You guys did this very recently.
Mm-hmm.
Okay.
Yeah. We're gonna go through the timeline really soon. Yeah, the deployment was in November of last year. Yeah. So we, as I was saying, this is about the replacement of pumps, but it is also about addressing certain challenges that we knew were there, and we're all related to a couple, and we're all related to how we handle this kind of equipment. And maybe you have the same in your hospital, so a centralized distribution and cleaning. So devices like infusion pumps, sequential compression devices, feeding pumps, and things like that, they're used with a patient. The patient gets discharged. The device is theoretically put in a sole utility room, picked up by a supply chain. We call them the central issues team. So a central issues staff member picks it up, brings it down, cleans it, process it, makes it ready for the next use. Then whenever the floor needs a new feeding pump or infusion pump, they call central issue and say, I need this. And so this is how the process was supposed to be. But and this process ensured consistent cleaning with the correct supplies, with the correct procedure. But of course, this was not happening at least half of the time. So the cleaning was often done on the floor. The pump never went downstairs. In many cases, many floors. And so that meant that they were they clean, were they not clean? We don't know. Maybe the EVS team, environmental services, cleaned them with cleaning agents that, of course, might not have been approved by the manufacturer, potentially damaging the equipment itself, or increasing the risk of infection, right? So why were they not following this process, right? Certain floors. Well, not all floors had par levels. Par levels are, essential in this process. But since many clean and solid utility rooms in our, very old building are not, very large, they never established par levels. And so whenever they tried to follow the process, send out the pumps, and then when it was time to need a pump, they had to call central issues, and it was not consistent. The time that took the central issues team to bring new devices was sometimes it was good, sometimes it was not good. And so they would rather keep the pumps on the floor, maybe hoarding them, hiding them inside cabinets or other locations of the ceiling tiles, or you name it. Very creative, very creative. In the nurse manager office, so there were secret stockpiles of pumps because they wanted to care for their patients, and the current system was not working. Huh? A lot. Oh my God. Yes. Yeah. That didn't help us with our EOC, percentage of completion. And
2 or 3 years, the first thing.
well, that's too late, right? We wanna, yeah. Whenever they show up, we all find out all these expired stickers, and so you understand it's a vicious cycle, right? So the fact of hoarding creates the shortage, the perception of shortage. And throughout the years, the organization actually purchased hundreds of new devices because nursing was we don't have enough pumps, and they're hoarding and they're hoarding. We don't have enough, so the organization purchased more and more. So we accumulated so many of these devices.
Well, that makes sense. So I was wondering why you had small purchase, big, or your
You see, it's yeah.
End of life
Mm-hmm.
schedule
Was all over
the. Just buy them all. But
yeah. So the other part, so hoarding and inconsistent cleaning are related, and then the mishandling of equipment was clearly also the actual transport of equipment was not done properly, and so these devices susceptible to more damage, being transported on up and down elevators, corridors. So we were actually seeing on our CMMS reports up to 50% of our repair work orders, up to 50% of our repair work orders for all medical equipment were due to physical damage related to pumps. And pumps only make up 20% of our fleet. So there was a clear imbalance. So the situation was quite complex, as you can see. The project overview. So the time frame was from the spring of 2023 to the fall of 2024. 1 year and a half from the moment we decided, let's do it, to the moment we're actually able to replace them at the main medical center. The other hospitals are still ongoing, but of course this was the largest implementation. So the goal was to replace all BD Alaris infusion pumps and establish a common standard throughout the health system. Huntington Hospital in Pasadena was using the Baxter pumps, Marina Del Rey the Plum pumps. So there was a wide variation. We wanted to reach a common standard, and we were open to consider other vendors as well.
On that, did you included the pumps that were recently purchased? Like, were they part of that, or?
I'll get to that. Yes, good question. I will get to that. Key stakeholders, of course, it takes a village, multidisciplinary team for sure. We led the project for sure, but we worked very closely with nursing, the user of the device, pharmacy, the provider of drugs and other, whatever is being infused, supply chain, both related to the central issues team and to, of course, the consumables, the warehouse is on the supply chain, which was also involved. purchasing, contracting, of course, supply chain was very much involved. Epidemiology had a big role too, because the cleaning topic was definitely a hot topic. Environmental services, as they helped with cleaning the devices in procedure spaces. We had pump and infusion centers outside of the hospital, so we worked with their leaders over there. The vendor had their own, project lead, project manager, that Gianna especially worked very closely with, and then IT. Our pumps were already bidirectionally integrated with Epic, with our electronic medical record, and of course, the integration needed to still be there, even if we transitioned to another vendor that was a non-negotiable. All right, so this is the timeline that will accompany us throughout our journey. The first phase was a 9-month phase and consisted in the vendor selection. How did we select our vendor? It was a 9-month phase, so it lasted, quite a bit because we wanted to do things properly. We worked with ECRI, which I believe you are familiar with. So we reached out to 4 vendors. We conducted an RFP process, a request for proposal. So we invited the 4 major vendors to respond to all our questionnaires and present their products. After that, we hosted vendor fairs in November of 2023, and then simulation trial. So we have a very cool sim lab at the medical center with actual ICU rooms and OR rooms, as if very realistic. So we involved, yes.
Is your current or existing vendor was part of that vendor fair?
Absolutely, yes, yes. A lot of nurses from med-surg, ICU, pediatrics, cancer center participated in the simulation trial. They went through some use cases, right? Normal use, troubleshoot issues, and so and their feedback was very helpful to reach a decision. So the steering committee took into consideration the results of the RFP questionnaire, the survey that we conducted after the vendor fairs, as well as the results that came of the simulation trial. A lot of factors. So based on the feedback, we selected a vendor at the very end of calendar year 2023. Afterwards, the negotiation phase began. It was another 6 months of negotiating, and that where our supply chain team took the lead. They were able to negotiate a very large discount. It's a multi-million-dollar project, an extended warranty. We trained our internal team to do clearly PMs. The warranty is now for 2 years. We can repair in-house. We can send out to them the pumps, and also the device check-in process was included as well. So that helped us during the implementation. So after the vendor was selected, we started our planning phase. Another 6 months of planning and IT work. So we decided to stay with Alaris eventually. The other vendors, were not so far that would have justified redoing the integration, redoing the training for clinical staff. Of course, would have been huge to move to another vendor. So we determined that staying with Alaris was our best course of action.
Did they grandfather in your training for repairs and stuff like that from the previous batch?
No, they came and did another formal session. Yes, yeah, there were very few changes for our technicians, but of course it was included in the package. It was not a separate line item. So planning and IT. So IT work was still necessary because new servers needed to be built. Actually, 6 servers, 2 for production, 2 for the training, and 2 for the test environment, so that the 2 systems could work in parallel. The current pumps would still be used and integrated with the Epic, our EMR, and as we deployed the new ones, they would also be connected to Epic. In October, we managed a production cutover. It was a very brief downtime where the new servers were connected with Epic, and that allowed us to test the devices themselves, test the communication. We tested the wireless connectivity, again, very little changes. And then finally, we created the device records in the EMR so that everything was set up for the integration to keep working. At the same time, the pharmacy team did their part. Again, very minimal changes for them too. They just updated their drug library, concentration limits, as well as guardrails. During the planning phase, we thought, okay, so when is the best time to exchange these devices? And of course, it was going to be different based on the location. For med-surg, for inpatient spaces, med-surg and ICU, we identified that the best time to physically swap the devices was whenever the usage was at its lowest. So since our devices are integrated, we are able to look at heart data and see how many pumps are infusing at any given time. So we did see daily trends, and 6 a.m. was the lowest, among the lowest time of the day, where if we, exchange the device then, we would have less issues with ongoing infusions, and most of our pumps would be available for a quick swap. For procedural areas, 5 a.m. was a good time, just before cases started, and that includes the PACU as well, pre-op PACU. And then for offsite locations, the leaders there, they preferred us to go after they closed for the day, so 5, 6 p.m. One of the changes we introduced along with this project, as you can imagine, given what we were talking about earlier, was the par level. We figured out we really needed to do something in order not to incur in the same issues with the new pumps. We needed to address that because cleaning on the floor was not an option. It has been explored, that option, but it was decided that in order to ensure that the cleaning, that the recommendation, that the recommended clinic practice, by the manufacturer, in order for it to be followed, it needed to be done by a small team in a centralized location. So the recircling of devices needed to work in some way. How? Well, we needed to establish and ensure that par levels were present in each nursing unit. Otherwise, they wouldn't trust the system. So we talked about our clean and sol utility rooms, very messy, very small. It was a matter of going one by one, reorganize, clean up, and establish some organization, I guess, with shelving units and clear signage, so that even if small, a decent par level could be established in each unit. So nursing agreed that with this process they would be willing to follow what was expected to ensure that again the pumps would be taken to the sol utility room after use, picked up, and then the central issues team would monitor these clean utility rooms to ensure that there was always precise par levels of brains and modules. Luckily, we have a real-time location system at our hospital. So that allows us to monitor how many devices are in each room without going there. So that helped us a lot.
separate from the one that's used in the pumps.
Correct.
Okay.
Yeah.
Good.
So we attach the tags, and we will see the tags. There is an infrared, emitter in each clean and solid utility room with a specific identifier. The tags reads that signal, sends it over via Wi-Fi or via a proprietary network to our server, and from any workstation, anybody can look where the pumps are. So this was instrumental for the success of the project. Try to virtually eliminate hoarding, reestablish trust in the system, and at the same time being able to reduce the quantity of pumps. And that's what we're talking about now, the quantities. So this project gave us the opportunity to reassess our fleet. We knew we were well above the industry standards because of these issues we talked about. So rather than blindly replacing one for one the devices, we sat down, analyzed utilization data based on how many pumps are used every day, where they are located, how many brains have not been used for weeks, right? Because we could see from the server, the certain brains were just sitting there, not doing anything. So great saving, almost $1 million worth of equipment that we did not replace because we knew that we didn't need it if the process worked as planned. Now, during the planning phase, we wanted to be prepared day by day. Gianna will go through the day by day list. We wanted to have enough brains and modules for those locations. So for med-surg units, on average, of course, we wanted to ensure we had at least one brain and two modules. One for the syringe PCA modules that might be on that floor. We would see that through RTLS. And then, of course, the additional per level that was recently established for that specific floor. For ICU, the standard or the average was 2 brains and 6 LVP modules, one for other modules and the per level. Procedure areas, it varied a lot. Certain ORs would not use Alaris. They have their syringe pump that are separate on the anesthesia card. So the majority of ORs, they don't use Alaris, but in cardiac cases, they do use Alaris. So we looked at RTLS, what it showed for that specific OR floors, and we would replace one for one. The PACU also had par levels, and then offsite locations, one for one.
All right, so the next month from September to October 2024, we had dedicated to preparing the devices. So we worked with BDLRS vendors on the check-in process, as well as work with all of those other stakeholders we had mentioned just to prepare and start planning for the actual device deployment. You want me to do it? Oh, oops, okay. So equipment logistics. So we actually had BD ship it to us in 2 separate shipments. So the first one was 24 pallets and the second one was 31 pallets that shipped to our warehouse in Torrance. So totaling about 55 pallets. And unfortunately, they did not have a record of what was on any of the pallets that were shipped to us. So we actually had to go out to the warehouse. They were stacked like 5 or 6 pallets deep, and I'm trying to see which devices are in each pallet. So we had to basically go out to the warehouse and take an inventory of what was on each of the 55 pallets. So thankfully, for the most part, there was only one device type per pallet. But as you can see here, this one was a hodgepodge of devices, and we had no idea what was on it. But we needed to kind of create a schedule to ship those things back to our medical center because they needed to check them in the order that we needed that specific device type based on the schedule we had. So we had created an estimated schedule with that, and it ended up being about 1 to 2 deliveries that we scheduled each week, and each one was about 5 to 7 pallets. So that number was sort of based on whatever the vendor could check in a given week, as well as we have very limited space to fit all these pallets in our medical center and in the basement. So that's what we could really fit in our hallway at the time. Well, we actually, I'll talk a little bit more about the schedule, but it actually, they had started checking in about 3 or 4 weeks prior to our check-in actually beginning. So we had a bunch of racks and stuff, but we started to put the new equipment on. But yeah, space was a very difficult challenge, as you'll see later on. This is hard, okay. So prior to BD coming on site, we actually had created a roles and responsibilities form for them. So that kind of detailed some of the check-in tasks that they were going to be responsible for. And that included the placement of a lot of the stickers we were going to have on there. So that included the CE sticker that we have here, the preventative maintenance sticker, the barcode stickers for the integration on the LVP pumps and the syringe pumps. And then those yellow dot stickers we had utilized, that was going to indicate that that was a new pump in the fleet. So signal for everybody. Yeah, they actually, BD actually, I had given them this, pretty much this exact schematic here and gave them that roles and responsibilities form. And I told them, put them here, any questions about it. And they were really good about putting that exactly where I actually told them to too. So if you tell them to do it, they'll do it. One other note about it is for the preventative maintenance sticker. As you might be able to see here, we had to have different due dates for different equipment types because we can't have our team do all 5,600 pumps in the same PMML in the same time. So just clearly lining out which device type was going to be due in which month, or for our offsite locations, we actually do them in a completely different time frame. So just letting them know ahead of time, please write this date on here. Yeah, question.
Because you already have everything kind of like as you're shipping it out to them and you check the date, doesn't that make it easier to schedule the PM?
Like to update any of the.
Yeah, you already have like the date and everything ready to go and it all is in one place at the same time. So
Right. So we basically could really organize it much better this time because everything was coming out at the same time. So obviously, you know, some of the things we started in January, so they had only been on the floor for 2 months at that point, but we already were PMing them just so we could set them on a good schedule. Well, for the most part, all of our main medical center is through our central issues department. So what we had did was all of the LVPs, for example, are due in March. So for the entire medical center, actual like on site. And then all of the PCU brains are due, I believe, in July. So that month frame, our team is just going around the facility looking for those pumps and using RTLS to try to catch all those pumps. But all of the pumps that are going to an offsite location, like through our medical delivery network, they're due actually in September. So they'll go on site there and onto that specific location and update them there. Yeah.
Just a comment, if your hospital is smaller, what we did is schedule the check-in where the exchange have been doing PM on. If you have a PM on for your devices, you'll have the resources instead of doing the PM, you do the exchange. Or some, if your hospital's smaller and have a PM on.
Yeah, got it. Great point. Yeah, thanks. But yeah, unfortunately, our team can't do them all in the same time, so we don't actually wait the full first year for a lot of the equipment, but yeah. And then one other thing that we had to do is disable the PM reminder dates. So because the PCUs are due in July, we actually start them in June, but we might not finish them for that 30 days after. So the clinical staff tends to freak out when they see the PM reminder on there. So we just had to ask them to remove that reminder date. Sorry. Oh no. I've done too much. Okay.
Oh, sorry. Did this one?
I think one more. Okay, yeah. Okay, so also for our BD check-in process, they completed about 200 devices per day. So thankfully, our central issues team had a little bit of space left over. So we actually had them organize wire carts as they were checking the devices in. What we tried to do for the most part is do, per day, have them put all the devices that were needed for check-in on that particular cart. So we could just easily, when it was time for that day in deployment, we were able to just take them off that cart and put them on our mobile carts and bring them to the floor. So yeah, most of it, we try to have them organized by locations, but we couldn't always do that. But yeah, about 200 devices per day, and they had organized them on the many, many carts. So another thing was going to be training for nursing staff. Thankfully, since we were going from BDLRs to BDLRs again, there was pretty limited changes for the clinical staff. One thing that we did want to note, though, is there was going to be some compatibility issues with the new brains versus the old brains. So the old PCA pumps, the syringe pumps, and the ETCO2 modules were not going to be compatible with those new PCU brains. Thankfully, and we have mostly LVPs, those are going to be compatible both with the old and the new. And then in terms of the actual changes to the pumps for the clinical staff, it was thankfully pretty limited. So they just had changed some alarm messages. So the alarm text change was going to go from no breath to no CO2. And then there was going to be a scrolling message change that said, instead of it used to just say a general occlusion error, and now it's going to say drive head error, so that they could communicate with the new ones. No, I guess they didn't want to actually flash these new ones just because they were going to be replacing them all at the same time. So there was just going to be that few weeks of those compatibility issues where the clinical team couldn't use the old ones with the new ones, and hopefully we'll get those out of the way as quickly as possible. Oh yeah, sorry, the untitled CO2 they did actually have to upgrade because they don't have the new ones yet, but all the rest of the fleet we were going to be replacing. So we did have to find all those ones. They flashed them with the new, and then they were able to communicate after we were able to find them all. Any other questions? Cool. So our next phase was going to be dedicated to the actual deployment of the devices. So from October to November 2024. So this here was our schedule. So on average, on our med-surg areas, we did about 2 floors, or was technically one floor, but 2 units per day. And then when we got to the procedure areas, we did about 2 floors per day. And then finally at the offsite locations at the end, we were able to do about 1 site per day because we actually had to ship the devices out to those offsite locations. So originally we had gone at a little bit of a slower pace we had scheduled for, so it was going to go over the span of 2 months. Then based on some feedback from some of the clinicians and stuff, we tried to condense it into 1 month. So it was going to be 1 month of a big effort from our team, but that would again prevent some of those compatibility issues of having both the old and the new simultaneously on the floor. Just they didn't want to have they didn't want to go too long with it, because then we would just have both the old and the new on the floors at too many times. So just to prevent, again, those compatibility issues of them having to put it on. There actually is an error message that would show up on the PCU brains if you connected an old one to it. Exactly. So just to prevent that kind of slowdown. Yeah, go ahead. No, we were able to, we had about 2 teams on site. So there would be one that would go to each floor or unit that was able to actually physically deploy. So we didn't thankfully have to do any overtime for our team, but we did have, I think, 5 or 6 people come in the morning, and then we had 2 people that were in the afternoon shift that would help us kind of prepare for the next day. For our weekly exchange schedule, we were able to deploy about 400 devices per day. So I don't know if you saw on the previous slide, but here we were only deploying from Monday through Thursday, and then we typically would use Friday as a catch-up day. So Friday we would go to any of the floors or units that we had completed that day, check to see if we could find any of those remaining old pumps that we weren't able to get on the first round, and then also just preparing for the next week's worth of lots of deployments. So that schedule worked out pretty well for us. Gave us that Friday, gave us that extra kind of catch-up day. So this equipment exchange process was the process we had actually coordinated with the clinicals team. So our process, we had brought the new equipment to the unit, and then equipment was exchanged in the rooms where it was available. So again, we use that clinical nursing staff. They, for the most part, if the infusion pump was being used, they went in the room and swapped it themselves. If it wasn't being used, then our team would just go in the room and switch it out. We also then stocked the par levels of the equipment in the clean utility rooms. And then in those rooms where they had critical infusions happening and we just couldn't swap it out at that given time, we had left new pumps for nursing to exchange as those infusions completed. And then once those infusions were completed, we had asked them to please place those pumps in the soiled utility room. Hopefully our team could come grab them if we saw it on our TLS system, or they gave us a call, we could grab them. If not, they went down to central issues. And then every day we were going to central issues and picking up more of those old pumps. So this was kind of the daily flyer that we sent out to nursing education. We had sent it out about 2 business days before the actual deployment was going to happen on their unit. So this just gives a process overview and gives some specific details. We had asked if it was safe for them to do so, to wait to start a new infusion until after we had arrived so they could just start it with the new pumps and not worry about it for the rest of the day. If they had a critical infusion and we were still on the floor, to notify us if we could still, again, we wanted to take back as many of those old pumps and prevent them from going back into circulation as possible. So if they had an infusion end while we were still there, to please bring it to us and notify us so we could take those old ones back. We had also given them instructions for the par levels that were going to now be in their clean utility rooms. And if they needed to still request additional pumps from central issues, we let them know, make sure you request the ones with the yellow dot stickers, because now they were a floor that had been converted at that point. In addition to this, we had also included a job aid that our nursing informatics team had put together, and that detailed some of those visual changes I had explained earlier, as well as gave a general overview of the cleaning protocol that they were going to be responsible for, which was very limited because all they had to do was put it in the soil utility room. So this was our daily process for our team and clinical engineering. So first thing in the morning, we double checked all of our quantities on our carts. So we had for each unit, we had one full cart that had completely new equipment on it. And then we brought up one cart that was completely empty so that we could put the old equipment on there. Then we would head to the unit with those 2 carts. And then we usually checked in with the charge nurse to begin the swap process in the available room. So on some floors, the charge nurse was super helpful and they actually went around the whole floor and went into every room and swapped it. On other floors, the individual nurses who were responsible for that room were able to help us. So it depended on which unit we were going to. So then we put the new equipment in, and as we removed the old equipment, we actually had to wipe it down and clean it before we gave it back to BD. So we thankfully had the assistance of some volunteers to help us wipe down that equipment. And then again, as I mentioned earlier, we left behind pumps in those rooms that we couldn't swap at that given time. And we actually asked nursing to give us a time frame of when they thought that infusion would be completed so we can come back up and pick up that old pump. So we had, let me think here, 1, 2, 3, 4, 5. We had about 6 technicians. There were a few days that we had to have some of our other technicians help out that are not necessarily responsible for the pump. So on a really heavy day, we had maybe 8 technicians that were doing various tasks in this thing. But I would say on a typical day, we had about 2 or 3 of them replacing just the batteries. Correct. Yeah, we had pre-purchased all the cradles. Thankfully, we didn't have to replace the batteries on everything. So some of that equipment that was going to be due in January, we didn't replace. You know, if we could keep track of which tags those ones were going to, we didn't replace the batteries on those. But for the most part, I think we ended up replacing just about everything. Yeah. Yeah, I think they would have put them on if we had asked them to. Unfortunately, we didn't have 56 extra tags to give them. So we were taking them off the old equipment. So that wasn't really part of their responsibilities because we just didn't have enough of the tags and they're really expensive. So, okay, so the RTLS tags, we applied them to the new devices. As Michele just mentioned, we had uploaded them with a scanner into an Excel sheet, and then we actually prepared the carts for the next day. So we had the quantities that we were gonna put on the cart, kind of like Michele had referenced earlier. And we actually had to charge the PCUs again because a lot of the PCUs we were grabbing were checked in 2 or 3 weeks prior. So by the time we were going to be deploying them, the battery was low. So we had to recharge them the night before to make sure that they were full battery. Okay, so RTLS. So I know we talked a little bit about this, but this is how we actually attach the RTLS tags on ours. So for the for the brains, we connect it to the actual power cable using 3 different zip ties. For these ones, for those cradles that you see there, we were able, for the PCUs, we actually reused a good chunk of them because we don't use the adhesive backing for the PCUs because they're tied on with zip ties. So we were able to just wipe them down, and as long as they were not broken and not too disgusting with other fluids, we reused them. For then the modules, we actually stick them on the back using that adhesive coating. So we needed to buy an entire new set of cradles for all those modules. Additionally, we had purchased a surplus of 400 tags, obviously, so we can deploy that first bunch, and then the rest of them, we were taking them off the old ones. And
it varies a lot. I would say between 1 and 2 years based on where they are located. So we have certain areas of the hospital that are not covered with the proprietary central network, so they use Wi-Fi, and they use Wi-Fi, it's more taxing on the battery. For those the tags that were usually in inpatient spaces where we have all the central infrastructure, they would last longer in that case because it uses a different frequency. So you couldn't really predict how long it would, between 1 and 2 years.
Well, I mean, I have never seen that one, but I've used other ones and the batteries wouldn't even make it to the next PM. So like, what's the point on it?
At that point, yeah. They should last at least 1 year. Yes. Yes. Agreed.
Okay, so kind of as we mentioned earlier, we thankfully had the support of some of the volunteers that work in our medical center. So with that, we had planned to coordinate with the volunteer program coordinator ahead of time because the schedule for the volunteers was going to be slightly different than their typical schedule. They were going to be starting a little bit earlier. Their shift was going to be longer. So they actually had to volunteer for this actual project. So during the actual deployment, they were really helpful. We had originally requested that they help us just with wiping down the old equipment as it was removed from the rooms, just so that our team could focus on the actual bringing of the new pumps to the rooms and work with the clinical staff. So they were able to actually save us quite a bit of time there with just wiping down the old equipment and placing it on that empty cart.
Where did you source these volunteers for, just out of curiosity?
Oh, we have a huge volunteering team at our medical center.
Oh, that volunteer to the medical center.
Mm-hmm.
Yes.
Yes. We tapped into that program already established. Yes.
And then so unexpectedly, we had finished a lot quicker on the actual deployment day than we were anticipating. So they were actually able to help us with the RTLS tagging. So they were assisted with removing all of the old tags from the old equipment. And then they actually had to help place the brackets. And then if the tags were all ready to go and the battery was changed, they helped to place them in the cradles and the brackets or with the zip ties as well. So that was a big help. So we had about 2 volunteers per day, additional to that, I believe I said 8 technicians. So we had a total of 10 people hands-on with that RTLS project because that ended up we had thought the deployment was going to take a bulk of the day. It ended up being the actual switching of the RTLS tags that took quite a few hours. So okay, so after the deployment, we have our post-deployment monitoring. So that took place in November of 2024. So we had a lot of space constraints that were unexpected, and I'm sure you guys have small space. You don't have much space either. So we had the new equipment that was going to be on those racks still. We were thinking that those racks were going to clear out a lot quicker than they actually did, and we were going to be able to just put the old equipment on there. Unfortunately, they were still taking up way more space than we had anticipated. So we actually had to end up sending the old equipment back to the warehouse, and then BD was going to do the return process directly from the warehouse. So we had we had about 24 pallets that we needed to end up shipping back to the warehouse, and we had shrink wrapped them and stacked them all crazy. So just so we could fit as many of them on as possible. But yeah, they were able to pick it up, thankfully, directly from the warehouse itself. So locating our old equipment, something we're still working on even months later to try to find those random stragglers. But thankfully, we had our RTLS system that was able to help us to find a good chunk of the old equipment. And so then, like I had said, on that Friday catch-up day, we usually would look at RTLS to see the units that we had already completed and see if there were any old stragglers from that floor, because they were still in circulation. Sometimes we had gone to that floor, and on that day, we had removed every piece of old equipment, and 2 days later, you would see another 3 devices pop up there. So we're still in ongoing working. We still have a few devices to find, but once the medical center was completed in our RTLS system, we actually noted the red siren icon for all of the old equipment. So then if anybody had tapped into the workstation and was utilizing RTLS, they could see that there was actually an old piece of equipment on that floor and send it down to us to help, notify to them and signal to them that that one needs to get out. Yeah. Okay, so par levels dashboard. So since we had these newly established par levels are in some areas, or either way, they had all updated the quantities, we wanted to utilize our RTLS par levels dashboard. So based on these new numbers. So in the dashboard, for example, this one here is 3 Southwest. So the par level they had requested was to have 5 PCUs and 5 modules on their clean utility floor. And then the minimum that we had put on there would just be 2. Just so it would alarm the central issues team. They would actually be highlighted in this blue color if that was below that minimum value of 2. So in this case, there's no PCUs or no LVPs on that floor. So this would, again, that blue box would just alert to the central issues team. That's a floor that we need to go stock because it's below that minimum level. And then because some of the clean utility rooms were not where they were when we originally installed the RTLS infrastructure, we actually needed to move some of the readers infrastructure so to accurately represent where those clean utility rooms were so that the central issues team could actually properly monitor where those are. So lessons learned, there was quite a few hiccups on the way, as you can imagine, but I'll go over some of the things. So associating the new pumps in the EMR. So sometimes we would go to the floor and the clinical staff was uncertain or not confident on how to actually disassociate those old pumps and reassociate the new pumps. So to mitigate that, I think including instructions for that into the job aid so that they're aware of that process would help to minimize those time delays. And we're looking on Epic to try to find the instructions because, again, yeah, I'm not sure of that process myself personally. Scheduling the exchange time. So even Michele had mentioned it was around 6 a.m. when the pump usage was the lowest. And we had even talked with nursing leadership and they had agreed to that time. The problem was that was around the shift change. So the shift change is about at 7 a.m. So at 6 a.m., when you have 1 hour left of your shift, a lot of the clinical staff was trying to close out their tasks for the day or before they went home for the day, or if the day shift had arrived already, they're in their morning huddles or whatever they're doing. So I think planning around that shift change, we would probably schedule it a little bit earlier or a little bit later, even if it meant that there was going to be a few more active infusions at that given time, just because we want to have, the clinical staff was a major part of helping us swap them out. So I think planning that shift around that shift change a little bit better. The space constraints. So our return process actually started about 3 weeks after we had started the deployment. So by that point, we had collected a lot of the old equipment and we last minute actually had to decide to ship the stuff back to the warehouse. So I think either starting the return process a little bit early, so maybe only 2 weeks or a week and a half after we had started that deployment would make that process a little smoother, or just planning well in advance to ship it back to the warehouse so we could organize a more streamlined process.
And they were okay with just getting them naked on a pallet with saran wrap around them?
Correct, yeah, and they actually put it on, BD themselves actually brought pumpkin boxes, they called them, put them individually. The BD team actually scanned the serial numbers for all of them, and they would give us a list every day of what they had completed for that day to return back, and they scheduled directly picking up from the warehouse those pumpkin boxes. So yeah, they were fine with us shrink wrapping them all and sending it back there, so they had no problem with that.
Yeah, they shared with us the only thing they needed is to be able to read the serial number. They didn't care if the module was torn apart. Yes, yes.
Yeah. Which there were still some that didn't even have the serial number stickers on the back, but they just had left that part blank. But and then lastly, ensuring the proper configuration, so our production versus our training server loaded. So in our fewer areas like our nursing education and our simulation center, they're actually obviously on the training server as opposed to the production. Well, BD we didn't quite make that clear enough to them that it needed to be on the training server. So we had deployed them on the production, and then our team had to go back and switch the configuration on them. So just making sure clear steps are told to them that, hey, this area needs to be on the training server, or this area needs to be on the production server. And then I would say our biggest challenge was just ensuring to engage the stakeholders as early as possible. So our nursing leaders, they're the ones that are actually communicating to their frontline staff that this project is coming for them. So yeah, I'm communicating to them early, and then establishing the PAR level. So that we went back and forth with, kind of as Michele had mentioned, back and forth with them quite a few times. So the original PAR level that they had requested was way higher than the actual quantity of equipment that we were going to be able to deploy out. So we actually had to go back with them a few times and say, this is your actual usage of pumps on a given day. And they were able to kind of lower that PAR level and make that a more realistic number. And then epidemiology. So they actually helped us to develop unit-specific plans for each floor based on where it was. So in the med-surg areas, they were going to send it down through central issues. In the procedural areas, our EVS team was actually going to wipe it down during the terminal cleaning of the room. And then they also needed to ensure that it was compliant with the IFU. So we needed to make sure it was practical for our staff to actually follow those rules, as well as still maintaining that compliance with the IFU. And then our central issues team, obviously there was going to be not only new cleaning procedures, but they were going to have a big increase in the quantity of equipment that they were going to be processing, as well as the PAR level areas that they were going to need to be stocking. So they actually had to hire additional staff members to support this extra workload. And they needed to obviously adjust their workflows and their routes that they were going to be taking for cleaning of the pumps. And then I kind of just mentioned this, but the environmental services team, so because they didn't have the equipment supplies, including those IUI connector covers and the proper wipes, we actually needed to make sure that they now carried that on their carts when they were going to be cleaning the pumps in those procedural areas, as well as we needed to train the staff on the proper way to clean them so that they weren't, rubbing the wipes in the IUI connectors or damaging the pumps with more wear than needed.
I know we are at time, we're almost done. But one aspect we had to monitor closely was adherence to the new cleaning protocols. So thanks to RTLS, we were able to pinpoint certain locations where we were not seeing, this is the number of brains that are placed daily in soil utility room. So certain floors just didn't put their pumps devices in the soil utility room, so they were not following the protocol. So thanks to this, we were able to work with our nursing champion to bring this up with the specific unit leaders, because ideally we were expecting an amount as close as possible to the number of patient discharges for that day. So we have the reference point. If a 7 North discharges 8 patients on a given day, well, we expect to see around 8 brains in the soil utility room in that day, and that was far from it for some floors that we were able to work with. Proper handling. Our repair rate for physical damage went way down, luckily, but we're still encountering, pumps still keep falling because they are transported, right, from the room to the soil utility room. And
So nice to the nurses.
Yes.
Because we know what's happening.
Yeah. So we are still monitoring this part. Hoarding has decreased a lot, but especially now that it's PM season, we are still finding a few devices. We bring this up to our nursing champion and try to reiterate the process. Inefficient use. This is a screenshot from Only Murders in the Building. Who watched it? Who watched Only? It's a beautiful TV series where when I saw this scene, I couldn't help but take a picture because I saw 2 brains with 2 modules. That's not something that should be done, right? Because 1 brain can have up to 4 modules. So we do see that also in our hospital and brought this up.
That's a better shot.
Yes. And finally, RTLS tags, something to point out. We work with volunteers. If you're planning to do that, make sure that the training also related to this is done properly, because we found out that many tags were starting to fall already because the appropriate pressure was not applied for the necessary time for the adhesive to be effective. And also the zip tie, hasn't been cut properly. So little things to be aware of. I know we asked, questions during the presentation. If there are other questions, please do. Otherwise, thank you so much for being here.